right, welcome everyone. Please continue enjoying your lunches, but we're going to go ahead and get started. Hopefully you realize you're here for the peer review Alzheimer's disease case conference and didn't just stop at the buffet. Our goal is to present a program that can help you build confidence in the visual interpretation as well as the quantitative analysis of neuroimaging, specifically around Alzheimer's disease. So I'd like to, again, welcome you. Phil Kuo, who will be leading the first part of this, is an expert in neuroimaging, and then I'll be talking about the quantitative aspect of this. I'd like to thank PeerView for providing this session, as well as Lily for providing an educational grant to support this workshop. There is a pre-event survey, so please complete it if you haven't done so already. There will be polling during the presentation. You can win cash prizes. Submit your questions, and we'll do our best to answer them during the Q&A session. We are pretty tight in terms of time, so we will do our best to get to them. Please use your personal device to scan the QR code on slides to respond to the polling and ask us questions. And then this is true for both the online and in-person learners. So here's the QR code. Here's your chance to win it big. Every time you answer questions, you'll have a chance of winning. And then if you see this "you won," that means you won, and let the peer review team know. Importantly, you can access this material and other practice aids online. This is a pretty dense presentation. And so if you're interested in reviewing some of it or learning more, this is a good way to access it. You can also email PeerView, and you can use X to participate as well. So goals, we're going to be talking about how amyloid is being used in the age of amyloid target therapies. You know, imaging physicians need to be ready to meet this demand. Probably some of you in your practice already have seen it. In patients with or at risk for Alzheimer's disease. As we'll discuss, amyloid PET is currently the gold standard for confirming amyloid positivity in the clinic. It's used to evaluate treatment response and monitor amyloid clearance. And I'll be talking about how quantitation can help support your visual interpretation and monitoring response to therapy. And in addition, we will be talking about how to communicate this with referring clinicians to improve patient outcomes. So with that said, Phil, take it away.
Well, thank you all for being here. And again, thank PeerView for all their great work. And I'm the opening act for John. And despite this format, thankfully, I don't have to debate John. I feel like there's supposed to be a debate here. So let's take us back to the beginning. And over a quarter century ago, when I was training in internal medicine, this is how we assessed Alzheimer's disease, whether it started from the pre-symptomatic stage to the mild cognitive impairment, and then once the dementia sets in, how it interferes with everyday activities. And this was the standard, of course, for a long, long time, but we have progressed beyond that, thankfully, to really biomarkers, which makes us far more accurate, of course, and allows us to stage this deadly disease. So many of you are familiar or have seen this. This is out of the paper by Dr. Jack, where it talks about the cascade of biomarkers from amyloid to tau to neurodegeneration. And the take-home point here is that the amyloid is the first category of biomarker to become abnormal in that critical cascade. The corollary to that is that amyloid is necessary but not sufficient. It becomes positive so early, it can predate symptoms by a decade or more. So the fact that you have amyloid does not mean that you have Alzheimer's disease. It doesn't even mean that you would get Alzheimer's disease within your lifetime. But you need it to have the diagnosis of Alzheimer's disease. It is the characteristic proteinopathy. So the pathologic staging system is recognized by neurology, okay? And the traditional one was the ATN, and then they evolved that to a more sophisticated state just recently in 2024. But the core one critical biomarker still remains amyloid, and specifically for imaging, amyloid PET. So an abnormal core 1 biomarker result is sufficient to establish a diagnosis of Alzheimer's Alzheimer's disease and to inform clinical decision-making throughout the disease continuum. And amyloid PET is an is a core 1 biomarker. Just for further detail, the core 2 biomarkers are later changing ones, and that is where tau PET comes in. So we get asked a lot about how to integrate, how does this increasing important field of fluid biomarkers work with PET imaging? Well, there are some important differences. As we know, with a blood test or a CSF fluid test, there's no regional information like we get with PET, okay? And remember, what you're getting from your fluid analyses are not the actual proteins themselves, but soluble metabolites that then get into the CSF or the blood. And also, very importantly, in this area, it's an era of neurotheranostics where we have the ability to do disease-modifying treatments. There's very limited data on using fluid biomarkers for monitoring treatment response. All that being said, fluid biomarkers are very important and widely used, okay? CSF, of course, there could be potential contraindications in any specific patient, much less being some difficult in patients with severe lumbar degenerative changes. And like any test, you can get false positives in early stages and false negatives. And like any test, also depends on your pretest probability. The blood biomarkers, while certainly increasing in data, still has limited real-world experience and may be affected by other patient factors such as kidney disease, which would affect obviously the clearance from the blood. And specifically again, for treatment and treatment response, still limited experience in PET and fluid biomarkers this is my opinion and shared by a lot of people, that they are complementary really, okay? They will be used together already and being used more in the future, but they are not interchangeable. They have important differences. So please get on your devices, take a moment to answer this polling question about AD biomarkers, all right? And I'm just gonna pause here for just a moment while you do that. And I'm gonna move on for the sake of time. Let's talk about the visual assessment of amyloid PET scans, okay? There's 3 F18 approved tracers, but they all have a similar basic principle of image interpretation, where they all will radioactively stain the white matter. Okay, so a normal or negative scan shows a white matter pattern of activity and no or little uptake in the cortical gray matter where your amyloid plaques accumulate in Alzheimer's disease. On the other hand, an abnormal positive scan shows uptake in the white and gray matter, so you lose that white matter pattern. Those are examples right there. Negative, you can take this cursor or your finger and trace out this white matter pattern, right? From the frontal to the temporal to the occipital. And in a positive scan, you lose that white matter pattern. You cannot trace out that white matter pattern. And the activity at the periphery where your gray matter is just as intense as it is periventricular where your white matter is. Okay, so gray matter out here, just as much activity as you see with your white matter, so you can't make out that white matter pattern anymore. Again, there's 3 F18 approved tracers. They each have their own reader training methodology, which was designed by very intelligent people who had access to the neuropathological correlation. So I would recommend making sure that whatever tracer you use at your institution, you do that reader-specific training. Very quickly, florbetaben and florbetabe are typically read in these grayscales, and fluidometamol is read in a linear color scale. There's also different regions that are used to assess positivity. So I would encourage the use of that specific tracer as reader training. Okay? Very importantly, nuclear medicine, traditionally in its inception, we were considered functional imagers. That's how we were different from radiology. And now we've moved to the Society of Nuclear Medicine and molecular imaging. And that sort of mirrors, if you have any pathology colleagues, how it's different. They used to just train on H&E stains and everything. Now they're doing immunohistochemistry, and they have molecular pathology, just like we have molecular imaging. And in this case with amyloid PET, we're not really being functional imagers like we are with FDG PET. We're really being molecular imagers, where we are assessing the pathology. And that is how these reader paradigms were calibrated. So a negative scan correlated on neuropathology to none to sparse amyloid plaque, okay? And positive scans visually are correlated to levels of plaque on neuropathology that are moderate to frequent. And that level of plaque is consistent with Alzheimer's disease. All right? This is a paper I had in radiographics. So the first author is one of my great fellows that I had back in the day. And we have some very helpful signs. We love our signs in imaging to help you to interpret more accurately visually the temporal, occipital, frontal, parietal, and striatal regions specifically in flutamidamol. Okay, so nice radiographics article there that is included in the resources, peerview.com. So how to report these PET findings for referring providers, right? Because that is the output that we all have to do is our reports. That's how we're judged. What I and many others do is put in the impression a normal and negative scan. This is pretty much almost word for word, straight out of the prescribing information, indicates sparse to no neuritic plaques and is inconsistent with a neuropathologic diagnosis of AD. And right there it reflects what we're doing. We're actually being like molecular pathologists, right? Instead of a silver stain, we're using a radioactive stain. We don't say that this is consistent with Alzheimer's disease, right? Because you can have amyloid pathology and it not be the reason why you have any symptoms, okay? And on the other hand, an abnormal or positive scan indicates moderate to frequent amyloid neuritic plaques. Neuropathological examination has shown this amount of amyloid neuritic plaque is present in patients with AD. So a report that really correlates to what we're trying to do, which is give the pathology that's in the brain. Some other tips on reporting guidelines. At the very top in your indication, of course, you can do the indication for testing, the imaging technique, which we're all familiar with, comparison to prior scans if available, particularly including MRs. Findings, so in your findings you go into detail about which region may be positive or negative, also significant confounders such as atrophy that the neurologist might need to be aware of. And if you do quantitation, you can slip that in there, the SUVR, the centiloid value. And again, the impression though, keep it short and simple as we suggested, whether the amyloid deposition is overall positive or negative, and really would really deter people from saying anything's borderline unless there's a good reason, for example, a technical reason like patient head motion or something like that. Okay? Another quick polling question to handle on your devices. Give you another few seconds. Thank you all for doing that. All right, first case. We have a man who is 86 years old. He presents with increasing difficulty with memory for about a past year, so pretty recent. He also has a little bit more of a complicated history of another neurodegenerative disease, Parkinson's disease. Had that for a few years. You can develop a Parkinsonian dementia, but that usually happens, years and years after your diagnosis. Also, additionally complicating, has a positive family history of Alzheimer's disease. So reasons to be concerned, but also reasons, that the symptoms may not even be due to Alzheimer's disease. Start with the big picture of his whole amyloid scan. Typically, you want to start at the cerebellum and then go to the vertex because you want to get an idea of what your gray-white matter differentiation is your cerebellum, because your cerebellum, unless it's very, very rare case, will be free of amyloid plaque. And then you'll march up into the temporal, occipital, frontal, and then the parietal regions. We're going to actually go region by region, and I'm going to show you the correlative MR that she had to really emphasize that you should be looking for that white matter pattern, okay? So this is the cerebellum, and this is the white matter, the cerebellar peduncle. So you see that has good uptake and very little activity in the cerebellar gray, okay? Now we come up here and look at the temporal occipital region first. Right, this is the white matter pattern, very clearly seen on the MR. As you can see, bilaterally, you have a clear, what we like to call the white matter ridge pattern. It looks like a mountain ridge in the desert without any trees, and the temporal occipital. And this looks like essentially the exact same thing as the white matter pattern depicted on MRI. So the temporal occipital region here is negative. It's always important to look at both sides because you only need one region, one side to be positive for the whole thing to be positive. So carefully inspect both sides. Come up a little bit higher to the frontal region. Okay, very common appearance here. Some people call this the trident, or I call it like the cartoon hand sign. Clearly see excellent gray-white contrast. And also make sure to check in the middle because you have white matter lining your interhemispheric fissure. So when it's completely negative here, you get this big area of no uptake in the center. It's kind of shaped like a diamond. All right. And then going into the parietal region, of course, you want to check the periphery, but sometimes that can be a little tricky due to atrophy. So always check the midline. Here's my tip to you. Don't forget that there's gray matter lining the interhemispheric vision on both sides. So when there's no activity there, you're going to get this nice big gap of activity. And I like calling this the convex lens sign. Okay? All right. And so, hopefully, what do you think about this scan? How would you interpret this amyloid PET scan? Please check on your devices. Big picture, does this have a white matter pattern, or do we have loss of great white matter contrast, which would indicate that you have activity in your gray matter with amyloid accumulation? Okay. Hopefully Yep. Actually, I guess there's a pause now for that. Does this move by itself? What's it? Should I start doing my air guitar, John?
It's being recorded, so no.
All right, here we go. All right, here's the audience response. Excellent job, everyone. 84% said negative. We have good white matter appearance in all the regions. So for this particular tracer, which is fluid beta period, that would be temporal, occipital, frontal, and parietal regions. You do evaluate the occipital region with fluid beta period. Okay. Actually, how do I advance this next? Oh, there we go. Thank you. So now, next case, we have an amyloid PET scan. We're going to start at the cerebellum and move towards the vertex. Okay, that's the big. Have you all take a look at that real quick. Okay, and what do you think about this one? Do we have a white matter pattern, or do we have we lost the white matter pattern? Can you take your pencil and trace out the temporal occipital ridge here? Is there a big clear space of activity centrally here, or is it filled in? Likewise in the parietal region as well. Okay. So, I guess they're not fans of the Jeopardy music. That's what I would have picked. All right. And the answer is, all right, great job, everyone. 90% answered positive. And actually, this is positive in every region. Hopefully you saw that. The temporal, occipital, oh, sorry, I should point that out. Well, I can't point it out. Temporal, occipital, frontal, and parietal were all positive. And one additional, yep, here we go. So that was clear examples of positive and negative, and John will show further examples. We're going to move now to a big change that happened over 12 years, where we evolved the appropriate use criteria, which was really developed in 2013 for amyloid PET, to the updated appropriate use criteria for amyloid and tau PET. When we were commissioned to do this almost 4 or 5 years ago, this was took a long time to develop this. There was a lot to discuss. One of the first things we did as a group was decide, even though they told us to do the updated appropriate use criteria for amyloid, we realized we had to do an updated appropriate use criteria for amyloid and tau PET, or else this thing would not be relevant very shortly. So, in very quick summary, amyloid PET is appropriate for MCI and rarely appropriate for cognitively unimpaired, all right? And in the very specific but very important new clinical scenarios that we had to add, which was to determine eligibility for treatment with an approved amyloid targeted therapy, the highest score of 9 for amyloid PET, as you can imagine. This is how we confirm that your target is there in order to treat with amyloid targeted therapy, the very basic foundation of neurotheranostics, right? And then clinical scenario 15 is a little bit more interesting, to monitor response among patients who have received an approved amyloid targeted therapy, and gave it also a very high appropriate rating of 8. And in case you're wondering, for tau PET, we actually thought it was appropriate for determined eligibility, but we need more evidence for monitoring. So in this new era where we actually have two FDA-approved, fully approved disease-modifying therapies, amyloid PET has really taken on a very important role. All right, and what about the data to support the use of neurotheranostics in treatment? This was the first fully approved anti-amyloid antibody therapy, lecanemab, And that was based on this. Unfortunately, you cannot stop the progression, but you can slow it. And this was highly statistically significant, where they slowed the decline compared to placebo when you gave patients lecanemab on clinical scores. But how do you prove target engagement? That was done on serial amyloid PET imaging. So patients with placebo had no change in their amyloid PET centiloid score, which, as expected, if anything, goes up ever so slightly. But as you can see with lecanemab, there was a very, very significant steep drop in amyloid PET quantification measurements with the treatment with the anti-amyloid. So now we've really proven that we got target engagement of what to expect to go along with that slowing of clinical progression. The second anti-amyloid antibody therapy to gain full approval was donanemab, and that was in the Trailblazer 2 trial. As you can see here, also in the all-important clinical scoring, slowed down the progression of disease in the donanemab arm compared to placebo. They actually added tau PET into this trial and showed that in patients with low to medium levels of tau, they did better than if you did not stratify by tau at all. But even in the completely unstratified by tau patient population, there was still significant slowing in cognitive decline. And likewise, with donanemab also, marked decrease was seen in amyloid PET on serial imaging with centiloids. And they did something that hadn't been done before. In this phase 3 trial, they actually used amyloid PET to monitor and then manage patients like we're used to doing in oncology. And amyloid PET scans that had a centiloid score of less than 11 would result in stopping the donanemab. And if there were 2 consecutive scans with centiloids between 11 and 25, that also would result in a switch to placebo, with the very logical assumption that if you've become negative for amyloid in your brain, what's the use of continuing to give therapy that may cause side effects? Okay, and with that, I'll hand this over to John.
Great. Thanks, Phil. So we're going to shift over and talk more about quantitation in this part of the talk. And so one aspect of this is assessing with accuracy of visual reads. And I do think there's a role, but I would say in our practice, and I think the evidence suggests that estimating the severity of amyloid burden, which can influence the diagnosis and treatment decisions, as well as measuring changes in the amyloid burden during or after treatment with amyloid-targeted therapies, guiding treatment decisions, for example, whether to continue or discontinue treatment, are probably the biggest areas where we find quantitation helpful. When we first started doing this clinically, it was often 18 months, moved back to 12 for some patients. And we're sometimes imaging patients as soon as 6 months after starting amyloid-targeted therapy, and in some cases seeing essential complete clearance. It is now recognized by the FDA and part of the label information that for all 3 approved F18 labeled tracers, the quantitative analysis can be used either SUVR or Centiloid scale. So the basis of current measurements are these SUV ratios. I've shown from a research scan segmented parts of the brain which are the target regions for amyloid, so in the cortical regions. So that's our SUV in the region of interest. And then we want to divide that SUV by an SUV in a reference region. Typically the whole cerebellum is used, although other reference regions have been proposed. And so we get a value that's a ratio. And this can work very well for individual tracers and methodologies, but standardization is the goal of the Centiloid scale. I'm not going to go through this in great detail, but basically Centiloids are SUVRs that are measured in your scan that have been normalized through a linear transformation to a standard value that you should be able to compare across different PET tracers and across different methodologies. And the basis of the Centiloid term is the 0 to 100 scale, where the SUVRs for healthy controls who should have no cortical amyloid are set at 0, and patients with typical AD, their SUVRs are used to set that 100. And so here's various linear equations for tracers in this publication. But the main point is SUVRs work, but if you want to compare, Centiloids are a better method. The other thing to note is, there's sort of a range of Centiloid scales, 0 and I think essentially everyone would agree below 10 is negative. You'll see kind of 10 to 15 is the threshold for positivity. And above about 30 to 40, kind of clearly positive by visual rating. And as you move up, you get to more typical AD. But I think this group is quite interesting. That's often the group where you can have the most challenge interpreting it visually. And this may be a different group in terms of their prognosis and the biology and stage of Alzheimer's disease compared to those who have high Centiloid values. And the point is that somewhere around 24 to 30 Centiloid units, most people are going to read these as positive. But these people, if you look at their if you have autopsy information, often will not have neocortical tau. So these people may be, although we can't make that assumption on an individual basis. In general, these people will have earlier stage disease. And so while we're asked to rate our scans as positive and negative, we call these borderline positive or borderline negative. Some people call it intermediate. But bottom line is, I think you should think about for your clinicians, make sure they understand what you're saying, but think about differentiating this group from the people who are clearly positive or clearly negative, both visually and on Centiloids. And we'll show some examples. So Centiloid and visual reads tend to perform quite similarly. There are some discrepancies, but then there's discrepancies between even expert readers. And so while it can help, and there is some data suggesting that, particularly with new readers, it may boost performance some, there's generally good agreement, and roughly 85 to 90% of cases, there's good agreement between Centiloid values and visual reads. And you can see, this 24 was used as a cutoff in this study. But one thing I'd like to note is people often get hung up on, well, what's the right cutoff? Is it 12? Is it 15? I don't really truly know the answer. I showed this. This was a comparison with industry sponsors' reference standard with two different commercial softwares. And the main point is that in 10 to 30% of cases, there's over a 10 Centiloid difference in the analysis of the same data set. So importantly, these are not extremely precise values. And so, trying to differentiate 12 from 14, I don't know if that's reasonable. So in terms of how to use these clinically, I like to perform the visual read, make my mind up, see what the Centiloids show. And we do see discrepancies. Some of this may be an error in reading. Some of this may be an error in Centiloids. Some of this patient is right at the edge of positivity, both visually and quantitatively. I always look at the ROIs that define the SUV ratios, the SUVRs that are then going to be converted to Centiloids. I look very carefully if it's discrepant between my read and the quantitative value, but that's a good quality control check. And you may have cases where you can't resolve which is right, the visual or the Centiloid. In those cases, I report that there's a discrepancy. Sometimes, and often in our patients, we've had plasma p-tau217 measures, so I may comment on that, but that may be a case where additional biomarkers are needed, and you may want to look at that if you have time and put it in your report. We report the Centiloid values as well as if they've had prior Centiloid values measured. And if you're able to, if your goal is to monitor changes in Centiloids, try to use the same scanner, the same amyloid PET agent, the same reconstruction, and the same software. Centiloids do allow comparison across different techniques, but you will get the best results if you can keep as many variables the same as possible. And finally, and I think this is true throughout medicine, and it's certainly true in nuclear medicine, don't let quantitation alone override your clinical judgment. I'll show you a couple of areas where I think the visual read is clearly correct, where the quantitation is wrong. We also see some artifacts. We don't have time to go into great detail, but the Centiloids can be off, either due to an error or due to the method. So here's an example of a quantitatively negative scan. Just visually, you see nice gray-white differentiation like Phil talked about. These blue ROIs are various brain regions, and this is using a commercial software viewer. If you have different methods may have different readouts and different ROIs. So the Centiloid value is less than 0. That's okay. That's not necessarily mean there's an error. We see these. And this is a visually negative and a quantitatively negative study. There's also some of the key regions where you can see SUVRs reported as well. And sometimes they use that for quality control, and you'll see that in some of these as they come up. So clearly below 10, matches the visual. This is a straightforward negative case. Here's a case where I hope you can see there's really reduced or loss of gray-white contrast really throughout the cerebral cortex. We have maintained gray-white differentiation in the cerebellum. The ROIs look reasonable. It's a clearly visually positive case. The synoloid value is over 100 in this instance. So again, this is a concordant study. But we have seen cases where the synoloid value is out of whack. It's more positive or less positive than we might think visually. So don't just assume just because they match. Still take a look at the ROIs, make sure there's not an obvious error. So here's a case that I would consider visually borderline. I think it's a tricky case. It's particularly tricky for you guys seeing it in grid format, not being able to review it. But I think there is some decreased gray-white contrast in the temporal and occipital cortex, and maybe also extending up into the parietal. But it's subtle. This is a case that is challenging to read, I think. I often will look at these in the coronal plane because it allows me to have the cerebellar gray-white differentiation and the cerebral cortical differentiation in the same plane. And so we can see, I think, slice after slice, there's some reduced gray-white contrast, for example, in the temporal cortex. But this is a challenging one, I think, visually. And the synoloid value comes back at 15. So, I think the question is, how do you report that? And how do you deal with that? So this person had a CSF and actually were positive. So this fits with our visual and our quantitative interpretation that there is abnormal amyloid, but it's at a low level. So when you have a borderline case, and it'll depend on your practice, but I would guesstimate 10 to 20% of our cases kind of fall into this challenging. Many are easy to classify. First, look at the PET images. Make sure there's not an artifact that's explaining this discrepancy. Could it be motion, attenuation, correction? Cortical atrophy, which you'll see in a substantial number of patients, is another issue. And I would recommend checking the synoloid ROIs in all cases, and certainly if you have a visual discrepancy. If you still believe it's borderline, again, I think comparing with plasma and CSF in your report, if you can have access and if you have time, is good. That's certainly something hopefully the referring physicians know, because there are cases that are challenging, and that's true for the fluid biomarkers as well. I try not to tell my clinicians too much what to do, so they don't have a reason to ignore me. But depending on who's referring to you and their level of knowledge, you might say consider additional biomarkers if you're confident that you really are dealing with a borderline case. But some of that's also going to depend on the clinical picture and clinical questions. So my advice, like I said, we are calling these borderline positive or borderline negative. Some people might call it intermediate. You could use another term, but we have started trying to be clear when someone doesn't fall into that clearly positive or clearly negative range. I would avoid the term borderline or indeterminate alone. As best you can, assign it as positive or negative. And if there's a discrepancy with the quantitative interpretation, state that that's okay. There are going to be cases like that. And that then flags this for the clinician to understand that this is not a straightforward case in terms of amyloid PET. They may need to do further investigation. And I think it's always good if you can to communicate with your referring physicians if it's feasible in your practice. But even if you're not talking about cases, really trying to be on the same page about what you're communicating, especially around these difficult cases. And we are fortunate that we have a good relationship and easy communication with our neurology group, treating these diagnoses and treating these patients. But I think as long as everyone's on the same page, there's not a single right way to do it. But again, we've found that having this negative, borderline positive, and positive as a way to flag those cases that are in the intermediate or borderline range and challenging on amyloid PET. So let's look at some cases to illustrate this. 68-year-old woman has mild cognitive impairment but has good functionality. She does have risk factors for cardiovascular disease. She has impairment on her Montreal Cognitive Assessment with executive and visuospatial defects. So, these two suggest AD, but she does have a lot of changes on MR suggesting vascular disease. and chronic infarct. So she's has multiple reasons potentially for cognitive impairment. Here's her amyloid PET scan. So I realize you guys are a bit of a disadvantage the way it's presented. Good gray-white contrast in the cerebellum. Again, this is, I think, a challenging case, and I'm showing those to illustrate how visual and quantitation work. I would argue this patient does have mildly reduced gray-white contrast throughout most of the cerebral cortex. It's subtle, and these are the cases that can be really challenging. And her Centiloid value is 23. So that would kind of fit with, a visually challenging case. I would read this as positive. And the Centiloid value is also right around the cutoff where it becomes relatively easy to call positive. So what would you guys say about this scan? If you were interpreting this, what would you give in your impression? Visually positive and quantitatively borderline positive? Visually negative and quantitatively positive? Visually borderline and quantitatively borderline? Or visually negative and qualitatively indeterminate? Or not sure? I'll give you a couple minutes to answer. All right. Yeah, and I think this is one that is a challenging words, and it's a little bit depends on what you think. I think the best answer of these is visually positive and quantitatively borderline positive. I also think it would be reasonable to say just quantitatively positive. It is not, I think, visually negative, and so that eliminates choices 2 and 3. Yep. That's right. I mean, and this is a challenging case. The reason I don't like visually borderline is because I would try to give an assessment of positive or negative. I would reserve that really for cases where there's a clear reason you can't interpret the study. Maybe it's semantics, but I believe this is a case that if you use the reader criteria, you should call it positive. And like I said, I would try in every case to try to state whether it's positive or negative. All right. So it's kind of in this borderline zone. They did have a positive p-tau217. And I think what's kind of interesting, in addition to the imaging and interpretation point, is at this low level of amyloid burden, it's at least worth thinking about, does this patient have multiple causes or even just a different cause of their cognitive impairment, and they just happen to have amyloid pathology. Now, this still could be cognitive impairment due to Alzheimer's disease. I can't tell just from this imaging, but given the MR, given the low level of positivity, this is a patient where you want to think, could something else be going on? And that could be important. They still might be a good candidate for amyloid-targeted therapy, but you'd want to make sure there wasn't something else going on that isn't going to respond. So that's why it's important from the clinician's point of view to distinguish this from someone who's just clearly positive. All right, let's go to the next case if I can. Great. 76-year-old man, increasing forgetfulness, has issues with orientation and serial 7s on his cognitive testing. He has some mild microangiopathic changes. So again, I think this is a challenging case. If we kind of get our eye set for gray-white differentiation, I would argue that in regions in the occipital cortex, particularly here kind of right medial, it's reduced gray-white contrast on multiple cuts. I think also there's some generally reduced gray-white contrast in the parietal cortex, but this is a subtle case. But I think this is visually positive, and you can kind of contrast the posterior distribution of gray-white contrast to the frontal, which I think is clearly different. So I think this is I would interpret this as visually positive. And again, just trying to show, if you have questions, trying to use anatomic imaging to correlate and make sure you're really looking at cortex. But their Centiloid value came back as 3. So if you buy that this is a positive case, which hopefully you believe me, I would say this is discrepant. And why is that? And in this case, this is in part because, and this is a well-known issue with some of the Centiloid regions of interest, they really don't include the occipital cortex very well. and they're only sampling parts of the rest of the cortex. So you can have, it's not the typical pattern, but you can have deposition outside of these typical regions. And so a clue here is the precuneus posterior cingulate areas where you often see deposition. And you can see these stand out above the other regions. So not perfect, but that's another hint that you're dealing potentially with regional distribution and deposition that doesn't match the synoloid ROIs. So how would you interpret this PET scan? Visually negative and quantitatively negative? Visually positive and quantitatively negative? Visually borderline and quantitatively negative? Or visually negative and quantitatively indeterminate? Or the fallback, I'm not sure. Oh, I got a different song. All right. Excellent. So I agree. I think the best answer here is visually positive and quantitatively negative. Now, I do think, you could have an analysis where you could quantitatively show there's deposition in regions, but based on the synoloid, they are negative. But I would explain in my report the discrepancy is likely due to ROI placement. And so, this is an issue with the ROIs. As I mentioned, looking at precuneus and posterior cingulate, particularly in this case, the precuneus, is important. You mentioned the discrepancy in the PET report. And if it's important, comparing with plasma or CSF values, if it's important to resolve this, could be done. So in terms of therapy response, we're often using it to confirm plasma Alzheimer's disease testing and set a baseline prior to amyloid-targeted therapy. So even when we have positive plasma biomarkers, we're typically doing amyloid PET, partly to confirm and partly to set a baseline. And currently, amyloid PET is really the only way that we can measure amyloid clearance and make treatment decisions around amyloid-targeted therapy. And complete treatment response occurs when amyloid PET drops below levels of positivity after treatment of amyloid-targeted therapy. And you'll often, in some cases, see partial clearance, particularly if you're doing earlier time points after starting like 6 or 12 months, where the PET level the amyloid level has dropped, but it remains above the positivity threshold. What cutoff to use, I don't think is entirely clear, and I think we'll have more information about this in the future. We use approximately 20. If you look at the Trailblazer data, if you're below 11 or have below 25 on 2 consecutive, that was considered sufficient to clear. Often we do the repeat 12 to 18 months, but particularly for people with low amyloid getting donanemab, we have been doing some at 6 months and have seen complete clearance. So let's illustrate this with a case. 67-year-old man, worsening memory over the past 3 years, not able to do some of his important daily living tasks. He has some comorbidities, but they're controlled. MMSE is not very impaired. Some microangiopathic changes, comes to us with a positive plasma test. So likely has AD, and he's interested in amyloid-targeted therapy. So finally, catch a break. You're in the reading room. Hopefully this is an obviously positive case. So it's positive and has a commensurate synoloid value. The ROIs look reasonable. So this patient went on to get amyloid therapy. This was done at 6 months, his repeat amyloid PET. And, you could argue is there maybe a touch of residual, but I would read this as negative. And there's clearly been a lot of clearance. The top is pre, bottom is post at comparative slices. Now you can much better see gray-white differentiation throughout the cerebral cortex. And so his synoloid values are 0. He's had a large drop, and this is someone who could stop therapy based on synoloids. So how would you answer this? Sorry, I kind of gave it away, but how would you interpret this amyloid PET scan? Someone who's currently on treatment, what should happen next for this patient? No, how would you interpret this? No amyloid clearance, continue therapy. Partial clearance, continue therapy. Partial clearance, discontinue therapy. Complete amyloid clearance, discontinue therapy. All right. So, I think we have overall a consensus that they've had complete clearance and can discontinue. Some people with partial amyloid clearance, there may be a decision to discontinue if there's been a large drop and the patient has having challenges tolerating the treatment or other clinical factors. All right, to summarize, so this patient, their Centiloid is clearly in a normal range. Stopping the treatment is an option. A question is, should we be imaging these people again if they have long survival to reinitiate therapy? We're not there yet, but I think that's going to be a question that may come up in the future. So just to summarize, the advent of disease-modifying therapies in Alzheimer's disease has really changed the way we practice neuroimaging in Alzheimer's disease. Amyloid PET is really the standard for confirming amyloid positivity and identifying patients who are suitable for amyloid-targeted therapies, although other biomarkers are important and play a role. Amyloid PET is also being used routinely to decide about continuing or stopping treatment. Hopefully I've shown you quantitation can support visual assessment. The Centiloid scale is a nice standardized method for deciding about positivity, therapy inclusion, discontinuation. I encourage you though, trust your visual read, use it in conjunction with the quantitation. Don't let one supersede the other, and certainly don't let the quantitation change your mind when you're confident on your visual read. If there are discrepancies, that's okay. Note them in your report. So we appreciate your attention and your attendance. If we have time, we'll try to answer some questions. Please scan the QR code to answer the final follow-up poll. And if you have questions for us, feel free to send them.
I think we're at time,
Yeah.
but so we are not insulted if you have to go to the next session, but we'll just start to answer some of the questions that are been seen real quick.
That sounds good.
Yeah, so one of the first question was, what is the correct way to window the Vizamyl images to avoid inter-observer error, since wrong windowing can make a study false positive or negative? The correct way to window Vizamyl images is to use the pons as your big band of white matter, basically. And it's supposed to be windowed at 90% of maximal intensity using a linear color scale, such as the Rainbow or Sokolov is common on a lot of the software. I think some of the challenges can come that the pons sometimes can get a little heterogeneous when you're actually trying to window it. I'm not sure what that is from. It could actually be to small infarcts, perhaps, that you can see on in the pontine white matter. That's pretty common when you look at MRI. In that case, I think the main bit of advice is to then switch to the cerebellar white matter as your backup to the pontine white matter, which is the first suggestion. The second one I'll just take also, which is better for the diagnosis of early stage AD, PET-CT, or PET-MR. I actually think it doesn't matter.
Agreed. I would say the main difference is if you're also want to look for safety ARIA scans, the PET-MR has a slight edge, but they both perform well in terms of the PET.
Go next one.
Yeah, so in terms of amyloid PET changes in known non-AD amyloid diseases such as ATTR amyloidosis, I think in the brain there is not an issue. People have looked at heart imaging primarily for light chain amyloidosis, but I think you could also see some positivity in the heart. I'm not aware of issues with either light chain or ATTR type in the brain. I worry a little more about amyloid angiopathy, but even then, I don't think that's a common confound. I don't know if you have thoughts on that, Phil.
Yeah, people ask if you should include amyloid angiopathy in the differential, and I think that is a slippery slope, because then you could put it on every single one practically, and it's just not common enough. And if they're going to go for amyloid targeted therapy, they're going to get the MRI to check for SWI and everything.
Right. I mean, I think if you saw it like in really focal in one region, there were microbleeds there. Yeah. I mean, I want more than just a positive amyloid
Right.
scan.
Without any other evidence to suggest going there every single time would just probably lead to more confusion.
Yeah.
Do challenges arise when a patient has a history of previous neurological insults, including surgery and stroke? Absolutely. The main thing, if you have any, particularly old stroke and you have atrophy or again any neurologic insult, is to avoid that area when interpreting amyloid PET. Really emphasize interpreting the areas of the brain that are the most normal, have the least atrophy. And certainly quantification will not help you at all and can actually give you a very wrong answer when you have neurological abnormalities.
The one thing I would add, the one place, especially if you're really using gray-white contrast as your interpretive criteria, I've seen a few people who have really bad white matter hyperintensities. That can lower the accumulation of amyloid PET tracers, and that can affect the gray-white contrast. Not common, but I have seen a few cases that have unusual appearances or even potentially false positives because of extensive, and I'm not talking about a few white matter hyperintensities, but talking about extensive.
Yeah. This question, I guess, how critical is the CT component to the scan? Would you be able to provide the same amyloid analysis with a PET-only brain scan, assuming attenuation correction by Atlas is a non-issue? Really, you know, the CT, and that kind of relates to the PET MRI question, you're not really, in typical interpretation, you're really just checking for areas of atrophy is the key thing that you're using for the CT. And even a low-dose CT does a pretty good job for the level of atrophy that we need to really confound the interpretation of that region and note to de-emphasize that area of atrophy and to focus on areas with less. So I don't think it would really affect much.
Yeah, and I would say, I think most of the software vendors have really designed this around amyloid only. I think that actually leads to some compromises in the way the Centiloids are done. But on the other hand, it really makes it independent of the anatomic imaging. So in general, only in a few problem-solving cases do I think it would be an issue. And those people should have had an MR before coming to you at some point. So at worst comes to worst, you know, you could recommend correlation with the MR if you don't have it available. But I don't think it changes interpretation in the vast majority of people.
I think this next one you could probably handle.
Yeah.
What is the Centiloid score number?
It depends who you ask, and it depends if the neurologist wants to treat them or not. So, you know, there's enough variability that I think saying this is the number is a mistake. I think everyone would agree 10 or less is negative. 12 to 15 is kind of where people start talking about the threshold of positivity. Roughly 24 is around the level where most people will call it visually positive and consider that a threshold for treatment. But I think saying someone with a Centiloid of 23 is different than someone with a... Yeah, they're playing me off.
Seriously?
The hook is next. But I think saying like a Centiloid of 23 versus 25 is different, is an error.
Yeah. And really, amyloid PET to qualify for you for you know, of course you could get excluded if you have, you know, old hemorrhages. It's really just the visual.
Yeah.
You don't need a Centiloid. If you can't process the Centiloid score, you can just use a visual interpretation and qualify someone for amyloid targeted therapy.
Absolutely. Yeah. I think they're useful, but don't feel, you know, our clinicians want them, but they recognize there's some patients we can't do it or there's issues.
Yeah.
And yes, you don't have to have that to make a correct interpretation.
I think that was a non-subtle.
Yeah.
We're done. Thank you very much.
Thanks for your
everyone.
attention.
Yeah.
Thanks for staying after.